Good afternoon, everybody. My name's Aaron Woodrick. I'm the director of the Domestic Policy Program at the Macdonald-Laurier Institute. Thank you very much for joining us for today's webinar on the theme of exploring innovation in Canadian healthcare. I think it's no secret to those of you tuning in, Canadian healthcare is in a bit of a crisis right now. We have very long wait lists. A lot of Canadians cannot find a family doctor or access much needed medicines or treatments. Money is obviously not the only solution. We've poured billions of dollars into the system, and yet we continue to be plagued with these problems. So innovation, which is a word that's very popular with politicians today, is something that is very applicable to healthcare. And I'm hoping that today we'll be able to get into some interesting discussions about innovations, both past and prospective, in areas including family medicine, medical technology, and the health charity sector. And to do that, we've got three great panelists joining me today. I'm going to introduce them one by one and then give them a chance to talk about what it is they do. First, we have Dr. Sean Bevan. She's the Chief Science Officer with the Arthritis Society of Canada. Welcome, Sean. And next, we have Tim Laudell. He's Director of Sales for Synergy and Skytron at Tribe Medical. And last but not least, we have Dr. Sean Watley, who is an author, policy fellow, physician, and perhaps most importantly, senior fellow with us here at the Macdonald-Laurier Institute. I want to welcome all of you to today's webinar, and thank you very much for joining us. And as I said off the top, I just want to give each of you first, before we get to some questions, an opportunity to talk a little bit about yourself and your organization. So Dr. Bevan, we'll start with you.
Thank you so much, Aaron, and it's so nice to be here today. So thank you for the introduction. I am the Chief Science Officer at Arthritis Society Canada. So we are a national health charity and really fueled by our donors and our volunteers. Our mission is really to fight the fire of arthritis through research, advocacy, innovation, information, and support for people living with arthritis. I think just to frame it for a moment, I think it's important for us to understand the impact that chronic diseases like arthritis have on Canadians. So for arthritis, there are 6 million people living in Canada with arthritis. That's 1 in 5. That's our neighbors, our family, our friends, etc. And such a huge impact on people's quality of life, their ability to work and to have productive lives. Never mind the fact that it costs our economy millions of dollars every year. So we think about the issues that you talked about at the opening of this session a lot. We've been able to do a number of innovative things over the last little while that I hope to share a little bit more about. But, including last year, we released a State of Arthritis report card where, we looked at, what is going on with arthritis in this country from a few different dimensions. And clearly there's a lot of work that we can do and a lot of opportunity for us to go forward.
That's great. Thank you so much, Sean. Tim, maybe you can go next.
Yeah, thank you, Aaron. Really great to get invited to this panel. It's been a hot topic my entire career. Waitlists have been part of this landscape of Canadian healthcare for as long as I've been in this field, and it's going on 25 years. And I've been with Tribe Medical for 16, and we've been partnered with a company, our parent company out of the States that is the most innovative company right now. Apologies, they're blowing grass outside my office window. Wonderful timing. And they've really changed the landscape of minimally invasive orthopedic surgery. So it really ties in well with what Sean's group is doing. But we've got lots of innovative products that have come out, and I've seen everything over the last 25 years to really make surgical procedures less invasive, so patients get back to work and back to their sport much sooner with better patient outcomes. So I'm excited to share some of those new innovations during this webinar. Thank you.
Great. And Dr. Watley, last but not least.
Thanks, Aaron. So Aaron put me on the spot and said you have to say what you do, and that's not an easy thing to answer right now. So I do a whole bunch of things. I started out as a just a regular clinician in the emergency department, and leadership in clinical medicine is not something people want to do. You kind of do it as a public service and to control your work environment. But once I got into that in emergency medicine, I realized that there was a huge opportunity to improve service for patients, but also to improve the working environment for doctors and nurses. And once you catch that bug, you can't go back from it. And so one thing leads to the next, and you end up with sitting in all sorts of leadership committees and then in medical politics. And from that, I've transitioned into more of a focus on policy work? How does our system function? How can we make it function better? And so I've had the opportunity to write a few books, and I've written a bunch of papers for with MLI. But I guess my primary focus right now is how do we bridge the gap between theory and practice? So I love ideas, I love policy, I love concepts, but just telling someone an idea won't necessarily change the way they behave, because really when we're talking about changing wait times and improving service for patients, we're talking about changing behavior. How do we change the behavior of our colleagues? And so that's where I'm really passionate, that bridging that gap or transcending that insurmountable problem between theory and practice. I think it can be done. There's a lot of energy and enthusiasm in the system today to change practice, but there are a lot of roadblocks that make change very difficult to come about. So that's where I'm coming from, and I appreciate the opportunity to be here today.
Great. Thanks so much, Sean. I thought what I'd do to start is I'm going to come back to each of you, maybe to chat a little bit about something unique to your organization, and we can get into some sort of general principles and how they may apply to what part of the health field you're in. Perhaps, Dr. Bevan, we can start with you. You mentioned the report card on the state of arthritis in Canada. We love report cards at MLI. We think they're very useful exercises. A little friendly competition never hurts. And certainly when you're talking about getting the attention of politicians, nothing like a failing grade to get them to try and pull up their socks a little bit. So maybe you could talk a little bit about what your report card found. It's sort of the top line findings of the report card, and what you'd like to see in terms of changes from policymakers to address any bad grades.
Yeah, no, that's great, Aaron. So just high level, we looked at a few different dimensions around arthritis in Canada. So we looked at access to care and treatment, we looked at different wellness programs, and we looked at research and innovation by lots of different metrics. And we came across some interesting findings. One in particular, and maybe not surprising, is that we have a problem with data. We know we've talked about policy conversations with health data in this country, but the same is true for arthritis data. So one of the key findings is that access to arthritis data is just simply insufficient. Another piece of the puzzle too is that arthritis research is certainly being underfunded across the country, especially when we look at that burden of disease that I mentioned earlier. And the last piece, not surprisingly probably, is that we see lots of problems when it comes to access to care for arthritis. So when we looked at all the provinces and territories that we could rank, the highest grade that we saw provinces receiving was a C. And there's certainly, a fair bit of work to do. In terms of what we can do, adopting different innovative care models will be really, really important. When we think about investing more in research and partnership among institutions, among health charities, among the government, really important. And then the other piece too, that just picking up on what was being said already about, wait times, a piece that we know is also important is around awareness. So we often talk about, say, surgical wait times, and hip and knee replacements are a big factor in those. So someone might say, oh yeah, I have a bum hip or a bum knee, I need to get it replaced. We much less frequently hear people saying, oh, I have arthritis in my knee, therefore I need that knee replacement. And the reality is that 99% of all knee replacements done in this country are done because of arthritis, and over 70% of hip replacements. So that awareness piece we think is also really important.
Yeah, that's an excellent point too. And boy, the highest grade was a C. I guess you didn't grade the provinces on the curve for that report card. I had one quick question about the data that you mentioned. Is it a question of the data is not being collected, or is it a data sharing and accessibility issue, or is it both?
Yeah, I think it's both. I mean, to be honest, we have seen some changes in how arthritis sort of surveillance data is being collected. So we would like to see some changes there, to be honest, going back to some of what we've done in the past to give us a much better sense of what's happening. But, especially when we're looking at the territories, we just have such a lack of data being collected in a meaningful way that we can understand, that we can really assess for this kind of thing.
Yeah, it's hard to measure things if you don't have good data. Tim, maybe we could talk a bit about your outfit and the kind of technology that Tribe Medical has.
Yeah, thank you, Aaron. I think the COVID pandemic really highlighted some of the technology that we have and its ability to get used quickly. With the wait lists and OR shutting down, MRIs virtually shutting down, we had a technology that could have been used in a surgeon's office to diagnose a procedure, diagnose a pathology, I should say, and do a very safe and effective job of doing that. The nano needle is the technology that we released in 2019, and it really, what Sean said earlier, it's the practical and the theory. It's getting these products into the surgeon's hands quicker, and getting these things. Not that they're approved by Health Canada. That's not the issue. It's getting them approved by provincial authorities, and we're starting to see a little bit of inroads in that now. But one of the reasons that we have patients that need total joint replacement so soon is because we're not doing a good job in possibly replacing their meniscus, or treating their meniscus, or treating the pathology at a younger age. They're not getting in soon enough. I can see Sean kind of nodding her head going, and some of the technology that we have would allow that, so patients don't have to wait months and months and months for an MRI. And then by the time they get surgery, that pathology has worsened to the point where they actually need something more drastic from a surgical procedure. So it's about getting patients in quicker, and the one way to do that is to get them out of the hospital, get them into either procedure rooms, or get them even in a surgeon's office setting to actually diagnose some of the pathologies that they're encountering.
That's interesting. Now, you mentioned briefly there, Tim, about these new procedures and new technologies, and it wasn't a holdup with Health Canada. Is it a matter of red tape allowing patients and doctors to access these technologies more quickly? Because I'm sure you'll appreciate that the trade-off is always between public safety and speed. So do you think it's just a matter of coordination that would help allow the process to just move a little bit more quickly?
It certainly is a matter of coordination and making sure that we can get in front of the providers, the money holders, to make sure. That's the one thing that I'm proud to say our company does, is we share, and we do as much upfront clinical work to show that it's safe, effective, and even cost effective. And this technology has shown all of the above, and yet we're still struggling to get it in the hands of surgeons. There's a couple, Nova Scotia Health has done a great job recently with their innovation hub and doing some pilot studies. We're working with them on that. There's Providence Health out in British Columbia is looking at a pilot project as well. So again, we're starting to see that, but it really is taking longer than it possibly should for technology that is actually the same or less expensive than what we're seeing in MRIs, and operating rooms are very expensive. They're $20 a minute or whatever the going rate is now. If we can get this technology into a procedure room where we have less staffing, therefore less cost, everybody wins.
Great. Dr. Watley, so I wanted to ask you, given your comments earlier about, turning ideas into policy, and, something like wait lists, getting people to change behavior, is there any low-hanging fruit in our system right now? We talk a lot about healthcare reform. Some people have very, radical ideas about healthcare reform. Others want to tinker around the edges. Do you see any sort of low-hanging fruit that changes that could be made that would change behaviors in a way that would improve things like allowing for shorter wait times?
Yeah, so we have a number of focuses or examples of success. That's a better way to put it. So we have a number of bright lights that have happened over the last few decades, at least in Ontario, but across Canada as well. I'm thinking Saskatchewan with their MRI wait times that we could point to and we could scale up. It's very difficult in Canada. It's been said that we are the land of pilot projects. Governments are very cautious about committing to a whole new program, even if the initial pilot shows good data, because once you commit to something, it's very difficult to shut it down or change it or even innovate. Let's say it's working well and you want it to work better. It's difficult to make it work better. So let me give you a few concrete examples. So there's a shout out to the Liberal government in Ontario. In the early 2000s and into the teens, they had a pay for results program for emergency wait times. And what they did is they attached even a small dollar value, as a few $100s, depending on how many hours a patient waited in the emergency department before they got admitted into the hospital. So that tiny bit of productivity incentive basically transformed the hospital administration from the C-suite right down. So within a few days or a week, certainly, of the announcement going live, we had the chief operating officer. So our hospital is large enough to have a COO, booking meetings with us every single week in our emergency department. And we pulled together all the internists and the surgeons and lab and DI and nursing and everybody. And they're saying, how are we going to get this $100 per patient or $400 per patient for the sicker people in a shorter wait time? So that's an example of where a small tweak in hospital funding makes a radical change in how administrators think. And so, as you know, hospitals are primarily still funded with block funding. We're one of the last countries in the world to use that approach. And despite attempts over the last 20 years to move to a more of an activity-based approach to funding, our hospitals are incentivized to show all the reasons why that won't work. Factory medicine or quality goes down or service goes down. There's a million reasons to say why it won't work, but even a tiny step towards activity-based funding goes a long way. So that's just one example of how you asked for low-hanging fruit. We wouldn't have to spend more, just spend differently on acute care. But I could go on and on, Aaron. You've got to turn me off, and
we'll come back to you. It's definitely not going to be the last word for you. I wanted to go to some sort of broader questions and talk about maybe where we live in now. Are there maybe some recent policy changes within the last few years that have impacted your organization or your company's ability to innovate or to deliver some of your services? And then whether or not there is anything recent, are there any sort of obvious changes at either the federal or provincial level that you could see that would improve your ability to positively impact the healthcare sector? Maybe Tim can start with you too. Maybe we could talk a bit about what's happened in Ontario recently.
No, certainly we're seeing the publicly paid private model start to gain some traction, and not just in Ontario, but in other provinces, Alberta, Manitoba. So we're seeing, the ASC model, or the ambulatory surgery center model, where, you're getting the sick patients out of the hospital, or the healthy patients out of the sick hospital, and getting those procedures done quickly. It's outpatient. I mean, even total knees and total hips now, they're really pushing the envelope and getting patients out of the hospital in under 24 hours or no more than 2 days. A lot of the procedures that we have products for have always been outpatient, whether it be rotator cuff repair or anterior cruciate ligament repair. Certainly for those laborers that have a lot of shoulder issues, those patients are getting done very quickly. And with those again, I hate to use the word private because they are publicly paid for. Those, we're getting more procedures done. They are much more efficient. They can turn over those cases much quicker. The average, caseload in a hospital with doing 4 or 5 total joints, they could get 6 or 7 now done, or they can get 6 or 7 arthroscopies done in a day versus 4 in a hospital setting. So it's certainly a more efficient process, and we're getting more patients through that system. So that's what we're seeing more of, which is exciting.
Yeah, and we'll definitely be talking some more about the blurry distinction between public and private services. Sean Watley, maybe we go to you next on this. You mentioned earlier the provincial Liberals move in the hospital. Is there anything more recent that you've seen as a positive step towards innovation in our healthcare system?
Yeah, so just leveraging what Tim just said about independent health facilities, we've had IHFs for decades in Ontario. There are over 900 of them, I believe, at last count. And then Premier Ford just announced recently that he would increase the number of those. So just to be clear, people are receiving care in those facilities with their OHIP card, so their provincial health card, not with their credit card. But the difference is that those facilities are managed, owned, run by private individuals. Most often they're physicians or they're groups of physicians. And so if that facility is not efficient, if it cannot provide services in an efficient and timely and high quality manner, they go out of business. And so they're very pressured to do as good a job as they possibly can. I mean, in our community, we have a few of them. If word gets out on the street that they're not giving great care, everyone says, don't go there. That's a terrible place to go
Right.
to. So this is a real issue. So in 2012, the Auditor General found that IHFs can provide the identical service to hospitals for 20 to 40% savings. So same quality, better service, and far more efficient. And we've seen a shift out of hospitals since the 1970s. So in 1975, 45% of healthcare spending went to hospital care. By 2020, it was 26%. 2022, we're down to 24% of total healthcare spending going to hospitals. And so I don't think it's abnormal or unusual or radical, despite what you see in the media, to be suggesting that, hey, now let's do hips and knees, even, or certainly knees or arthroscopy outside of hospital. And so I think we can encourage that movement. The risk, though, to be very clear, the ability to be efficient rests on the ability to innovate in these IHFs. And as soon as these IHFs get too large, they will attract a lot of attention from our organized labor movements. And so as soon as you unionize an IHF, now you have a second layer of management. So everything that management decides has to go through and be approved by the unions, labor relations, etc. And so that will grind productivity to a halt, unless the unions are also on the hook, where they're going to go out of business if the IHF isn't successful. So right now we don't have that in the hospitals. The hospitals stay in business no matter how inefficient they are. So IHF's great opportunity, and that's what Tim was talking about too, I believe.
Yeah, that's interesting. I think a lot of Canadians are shocked, though, at your insinuation that they might be able to have choice and be able to, like, they'll take anything they can get in a lot of cases. So the idea that they'd be able to pass up, a surgery at one place and go somewhere else seems like almost too good to be true. Dr. Bevan, maybe we can go to you about some of the changes that have affected the Arthritis Society.
Yeah, I mean, I would say, I already briefly mentioned the data piece, that obviously the data impacts our ability to understand what's happening and make good decisions. I would say that we've had some positive progress in terms of testing different models of care that work in different places. I mean, Sean previously mentioned, our land of pilot projects, which is a challenge. But certainly we've had opportunity to test different models of care where we've got, whether it be advanced care practitioners in arthritis care or physician assistants, whatever you want to call them, but people that can really help reduce the workload on the health human resources workforce right now. So how can those individuals that are trained to help diagnose, triage, provide some early care to people living with arthritis in this case? I think there's a lot of opportunity there, building on what Sean said, to expand that early work more broadly to deliver care more efficiently. So I think there's lots of opportunity. I think that a lot of it too does rely on partnerships and doing things right. And I think, health charities like ours, we have the ability to do some of this testing and this ability to try different things and hopefully be in a position to present it to governments in such a way that will be appealing for future funding and investment.
Yeah, absolutely. Dr. Wally, I'm going to go back to you because this touches on, you mentioned something about, about productivity and the ability to innovate. Obviously, advances in technology, advances in productivity are beneficial in that we can probably do more with less, especially important in an era when we're short on a lot of medical professionals, right? So if something can be done quicker or can be outsourced, that's just going to shorten lines. Do we run into a challenge here though when you mentioned the unions, increases in productivity in any sector are going to be fought by interests that have a vested interest in sort of retaining existing labor. So while if you have a shortage in labor, that's kind of come save the day. If you once you've eliminated that problem, there are going to be people sitting around grumbling about the possibility of lost jobs. So what do you see as coming down the pipe here as technology advances and the unions have to face down the possibility of actually we may not need as many of you as we thought we did?
Yeah, great question. So I've been saying for a few years that our whole system is based on the clinician-patient relationship, whether it's a doctor-patient relationship or the nurse-patient relationship, whoever it is, and that relationship is the linchpin, and I think it should be the linchpin of a system because it's a human-based, service-based industry that we're in. Having said that, if we get so bad and make people wait so long, we are going to see people bypassing that relationship to get answers to questions they're worried about. So for example, we already have point of care testing and wearables. We've had the ability for people to check their blood sugars at home, right? For forever. Now they can check their INRs at home. During COVID, everybody bought a pulse oximeter, right, on Amazon so they could check their O2 levels at home. And so I think what we're going to see is a leapfrog over the doctor-patient and the nurse-patient relationship to a technology-patient relationship. And I suspect that the regulatory beast will jump on that relationship, but technology will innovate faster than the regulators can keep up with trying to regulate that relationship. So we have smart toilets, right? It can check the protein in your urine every morning. We see how well your kidneys are functioning. People have been checking their blood pressures at home forever. So I think, you asked what's coming down the pike. I think that's what we're going to see because patients just get frustrated with waiting
Yeah.
so long. They need care.
People are already going to ChatGPT to self-diagnose their ailments, which is a double-edged sword there too. Because of course, if we can get some information, that's better than none. But there's always going to, whether it's self-driving cars or whether it's healthcare, there's always going to be concern if there isn't a human element. How much can we trust it? And speaking of that, I did want to bring up the topic of artificial intelligence, AI, which is something that has permeated. I can tell you, as someone who touches on a lot of different policy areas and a lot of different things, it's touching everything. And I wanted to sort of put it to the whole panel if there are any developments in AI or anything that you foresee in AI that would impact your area. I think there are a lot of people out there, when they hear AI, they're largely thinking about things like ChatGPT. They're not recognizing that there's a lot of other applications for it. So I don't know. I don't want to put anyone on the spot. If you have anything that you want to jump in on, Tim, I see you've unmuted, so there might be something that you'd like to share.
Yeah, certainly. I think one of the things that a lot of companies try to do is educate their surgeons on the best and safest use of the products, and that's something that we've been very diligent with, and we spend a lot of money with, and I think that's something that we're going to continue to do. You look at VR and augmented reality and training and that type of thing, and there's a lot of procedures that need to be, a surgeon should be practicing a couple times, and we have wet labs across the country and into the United States that actually allow a surgeon to practice that particular technique before they do it on a patient. So, and I think what we'll see is a lot of that, AI or VR, augmented reality, come to fruition to make it less expensive and more readily available for surgeons to get training and basically ensuring that patient outcome, that surgical outcome, will be the best possible one there is. So that's what I foresee happening, and we're working on it now. We're getting much closer to releasing some really cool technology in that regard.
Sean.
Yeah, just to build on what Tim was saying, I think there's just so many different applications that we're seeing in healthcare, for arthritis. And, we invest in a lot of arthritis research where we're seeing this being applied in many different ways related to the diagnosis, the care, the treatment, the tracking of patients. So lots of opportunity in terms of trying to understand, whether it's people's genetics and how that should relate to people's treatment plan or what have you. AI will certainly play a role. I'd love to share a little bit, though, that we're doing with a social impact project actually based out of the University of Alberta, where we're actually working with a clinical researcher who's using ultrasound and AI to diagnose a condition called hip dysplasia. And why it's so important is because if you develop hip dysplasia, you're almost guaranteed to develop osteoarthritis later in life if it's not actually treated. So in order to diagnose quickly, and especially in remote communities that might have less access to different things, we've been working with him to develop this AI-guided ultrasound device that can really quickly identify people who are very likely to have hip dysplasia and figure out what the next steps are based on kind of an AI module. So that's just one example that we are excited about, but there's so many different applications and so many different, conditions that we're going to see going forward.
That's great. Other Sean, you think that is AI going to put doctors out of work or what?
Well, for sure, yeah. So AI is a tool, right? And I love tech. I just, anything new and cool, let's go for it. Let's try it out. The risk right now, again, to my comments earlier about the technology patient relationship, the technology is changing so fast and being adopted so quickly that we're not able to keep up with our two very real risks in the room. And one risk is with data privacy and security. Certainly that's being baked into legislation in Canada, United States, and in the EU. But also there's an even more fundamental risk when it comes to dealing with patients, is that it's a risk of anthropomorphizing or turning this machine into a human, right? To feel like I can trust this AI machine and it has empathy. It makes me feel good. And so trust, empathy, morality, that does not apply to a machine. They are not sentient beings. And so they're not meaningful concepts in the world of AI. And so we have to wrap our heads around this. I'm not saying we should stop AI because of these challenges, but we need to, I think it's forcing medicine to redefine itself. So certainly having a computer help you come up with the best drug protocol in oncology when there's, thousands of drugs and they're changing literally, week to week as new research comes out. Having an AI like Watson and the NLP process to help you choose the right oncology protocol is a wonderful thing. Having said that, we also have to be very careful. Now, this is me maybe being too circumspect, but there's a difference between having a tool to help and having a tool to control. So a lot of the electronic medical record systems that we adopted were from the United States, and they were started out as billing programs so that the billing companies or the providers, the payers, could analyze very carefully based on your note what little aliquots of care you provided because you wrote it down on the EMR. And we always risk that as soon as you have a centrally controlled, centrally planned system and you get greater and stronger technology that captures more data, the human element is squashed out. I could give you concrete examples of how one diabetic patient is not the same as another diabetic patient, but the computer can't tell that difference. And certainly the administrator who's looking at a spreadsheet that has redacted information that the computer provided to them, they have no clue at all what went on at the bedside. And to realize that, this diabetic person just loves eating cake and they run it off and they get their sugar down that way. So don't torture them about changing their diet. I'm not advocating bad diets in diabetics. I'm just saying not everybody follows the rules the way we want them to, or follows good health advice the way we want them to. So fascinating. Love AI. I think it's creating it's forcing us to change, but it's not going to put people out of business.
Yeah, I was just going to say it's a tough distinction to make, even for AI. But that's and you mentioned off the top, technology to help versus technology to control. That also relates to data, and I wanted to go back to Dr. Bevan on that. One of the challenges we have, and one of your reports identified, is that we're not collecting data that we need. How do we? I don't know if you've had conversations with governments. I mean, do they recognize that this is a problem? We also live in a time right now where there's a sort of increasing sensitivity to, data being controlled or being in the possession of private companies and governments. So, I don't know if you can share any, like, are governments aware that they need to do something about the data? Do they have some trepidation about trying to collect it? Is it hard to collect? Are they in denial about it? I mean, I'm just not sure where most of them are when it comes to improving data collection and sharing.
Yeah, I think it's a great question. I think that, we've definitely had good receptivity towards the challenge. As we've seen different governments take different approaches to our national census, for example, and that has changed over the years, going back and forth. So I think there's certainly potential. I think, there's the opportunity to identify what the key pieces of our information are that we need. But back to the earlier point that we were making, there's a huge challenge with coordination. And if we don't get that right, we're never going to be able to put all the data together to make sense of what's what. So I would say, though, that people or governments that we've been speaking with acknowledge the challenge. We don't necessarily have all the solutions, but trying to understand where to focus and how to make sure governments are focusing on the right things.
Okay. Yeah, Dr. Watley.
Can I jump in on the data thing? Because the data comes up at every healthcare discussion. There's data and there's data. So not everything that we measure matters, and not everything that matters can be measured. And furthermore, even the measurements that we come up with are often totally useless. So in emergency wait times, for example, for years we had average wait times given to us the day after. So we would hear, well, your average wait was 4 hours or 6 hours. Well, average just means that some people got care in 20 minutes and other people had to wait 15, 16 hours. So
Right.
the statistician, this old story about the statistician who drowned by walking across a river that had an average depth of 1 inch or 1 centimeter, right? Well, the average doesn't mean anything. So we advocated for live data given to us in minutes. We needed to see wait time in minutes, and it had to be live. So it was changing, and we knew exactly how many people were waiting for how many minutes before we could drive change. So data is a huge problem, but it's even a bigger problem than that. So geek out on you here with Hayek's knowledge problem, right? So Friedrich von Hayek, a Nobel Prize winning economist, said that no one can have enough data and knowledge to be able to centrally control an industry. And that's what we're trying to do in Canada, is to centrally control an industry. Now, I'm not saying we don't get any data. Of course, we should get as much data as we can, but we need to approach that with a sense of humility, knowing that, you know what, we're never actually going to have enough data for us to be able to control it. And even if we could get enough data, no one's smart enough to do it, not even AI, to manage it centrally. So I think if we start from that presupposition that there's too much data and no one's going to be smart enough to use all that data, then we can use data in a prudential or a thoughtful way and say, okay, what exactly do we need to know here that's going to be relevant to our patients and going to be relevant to the people who are trying to care for those patients, and go after that. And then once we've collected some of that data, go back and say, well, did this meaningfully improve care for this group of patients? And not for all patients, not average. I want to know exactly, did it improve care for the 80-year-olds living in North Bay who live alone and they're widows or whatever? So we need to really figure out, because it's tempting to get beautiful numbers on a spreadsheet and say, whoa, look how we're improving the data, and it's meaningless.
Yeah, and I guess it's also a question of who's using the data, right? Like if data is disseminated out into more parties and we have a healthcare system that's decentralized in terms of control, then that can be of different use than if it's all held in the hands of a central authority, which then we're getting into 1984, and we don't want to go there, I know. Tim, I wanted to ask you, given that obviously as a private company, and if you, for example, you have to ensure that the medical authorities are satisfied that your products are safe, data must play a very important role in your work.
Yeah, definitely. I mean, Health Canada has actually made some improvements in the time it takes to get products approved. And of course, we can't get anything approved without proper bench studies, clinical studies. And it really depends on the implant, whether it's a class 2, which is just what one would term just a scalpel would be a class 2 device, versus a class 3 device, which is something that's implanted into a patient and typically lasts forever or is somehow resorbed. So class 3 implants take a number of weeks, if not months, to get approved. And of course, data that has to come, and that's typically handled by our parent company. But nonetheless, it can take as long as a year to get products approved in Canada. We've seen as long as 2 years with some of the MRI data that they need with this. And that too speaks to, slowing down, patient outcomes. We've got a lot of companies have a lot of innovative products that can speed up recovery and that kind of thing, but it's taking Health Canada a long time to get through these approvals. So it is frustrating, but we are seeing some improvements in terms of I'll be honest with you, up until about 2 months ago, a product group had to be submitted on a CD-ROM to Health Canada. It's now a cloud-based system, fortunately, but that's just happened in the last few months. So it does go to show that Health Canada is a little antiquated, and it is taking longer than certainly we would like, and I believe certainly a lot of our surgical colleagues would like.
I'm always reminded by the number of players in healthcare that are still forced to send things by fax. It might be doctors and lawyers are the only ones left using fax machines in 2024. Unfortunately, I'm curious though, Tim. You mentioned that Health Canada taking a long time. How do we compare to our international peers when it comes to the speed of approvals? Are we at the slow end, middle of the pack? Like, what is your experience?
We're definitely middle of the pack. I would say Japan's probably one of the slowest countries in terms of seeking approval. South American countries are slow as well. Europe is probably equivalent to Canada in terms of CE marking. So, we tend to compare ourselves to the U.S. and our U.S. colleagues will get products approved in a matter of 2 to 3 months or less, sometimes just weeks, depending on the class of the device. And like I said, we're typically 12 to 18 months for class 3 devices that are implants, which personally I think is just too long for our healthcare system.
Sure. Well, it obviously has impacts on patients, doesn't it?
It does.
I wanted to get into, we've been dancing around it a little bit, and Sean Watley, I know you've talked a little bit about the role of the private sector in healthcare, but of course we have Dr. Bevan on here who is representing a charity, health charity, and I think a lot of the time in these discussions when we talk about public and private healthcare, the discussion about nonprofits and charities is often left out of the conversation. So I don't know, Dr. Bevan, if you have any thoughts on what makes not just the Arthritis Society, but health charities generally, different than either of the two pillars of public and private, and what role they can play.
Yeah, I mean, I think one of the most important things that I think we can do as health charities is to remind people that patients are really at the center of this discussion. We've talked about it, I think, in this conversation already, which is great. But at the end of the day, all of this is for the patients. So, nothing for them without them is really important. There are so many different models of care or different funding approaches that can be put forward. And I think ultimately we have to be paying attention to measuring those patient outcomes that we're seeing. What are the health impacts that they're seeing? And, for a patient, does it matter if it's public or privately funded? As long as the care is there and the positive health impacts are being achieved, then that's very good. I think about, for example, things like the pharmacare conversation that we're having in this country right now. And again, there's probably a partnership model there between private and public systems. But understanding that, some of the most expensive drugs on the provincial formularies are for arthritis patients, we have to make sure that any system that we adopt or new policies that we adopt, it doesn't become that race to the bottom, to cover the minimal pieces of the puzzle there. So I think that's probably what I would emphasize, just reinforcing the fact that health charities can really bring that patient voice to these discussions.
Yeah, absolutely. Tim, you obviously work for a private company. How do you, and I guess I'm curious too, have you detected any change in attitude with governments? I mean, for a long time, it was no secret in this country, if you said private in the context of healthcare, it was almost like a third rail. Do you think that conversation has shifted in recent years?
I believe it has. I mean, I think, as we're starting to see these independent health units grow and expand. And again, I had a conversation this morning of another facility that's going to be up and running in a year's time. And it's going to be very impactful. So obviously they're having an impact with the government. And I think it's very positive. And again, it is about the patient. I think Sean said it best. This is all about the patient, trying to reduce our wait lists, trying to encourage, better care, faster care, better quality of life. And I think finally we're starting to see that. I mean, like I said, Nova Scotia Health with their innovation hub, they're doing some wonderful things and working on some new projects and working with us to try to get this new technology out to surgeons wholesale. They're doing their due diligence, as I think they should. but at least they're having conversations with private companies and publicly held companies to ensure that we're getting technology to patients faster. So it's exciting.
Great. Dr. Watley, I mean, I know you've written at length about healthcare reform. So, in a few minutes worth of conversation, I guess the question I put to you is, do you have hope that change is afoot? Whether that's Canadians being more open to reform that they hadn't been historically, or that we may have governments that are more open to it politically.
Yeah, so I think we have to always have hope. Despair is not a virtue. We're not going to get anything changed if we are all despairing. Um, a few comments, though, about the public-private discussion. Number one, we need to say up front that we are pro-universal care. Everybody gets care. And so this is not a radical concept. Last count, I believe there are 28 countries around the world that offer universal care. So every citizen within their borders gets care. So we can be very strong on that. We should be loud about it. We should say we need universal care and we need access to that care. So care denied or delayed is not universal care. So we can be very strong on that. But then with the discussion about private and public, I could go into sort of the details on private, but I want to give a concrete example of where we have private and public care right now in Ontario, and that's with respect to fertility services. So in 2020, Ontario funded publicly 5,500 IVF cycles per year, so 5,500. Well, a large fertility clinic can do around 1,000 cycles per year, so they can provide 1,000 cycles per year. Thus, based on the 5,500 number, maybe we would be able to have 5 clinics in Ontario if we only allowed publicly funded IVF services. Well, because we offer a mix of public and private, so people can pay privately for IVF services as well, in 2020, we had 13 fertility services clinics in Ontario. And so what that means is we have clinics in the far north, in small towns, well, not super small towns, but certainly outside of the core Toronto, sort of the mega urban centers. People get care closer to home. These clinics hire a whole bunch of people, so ultrasound techs, nurses, specialists, lab technicians. They buy a ton of equipment. It helps the economy. So people get better access, more access, a huge network of services because we allow that. And on top of that, people get shorter wait times for those 5,500 IVF services. So we already have this happening in certain small niches within healthcare. And people don't like to talk about it too much. They don't like to mention this, that, oh my gosh, some people are actually paying for IVF.
Mm-hmm.
But this is happening, and it's a good thing. Patients like it. They like not having to travel from Thunder Bay down to Hamilton to get their IVF done, and they can get pregnant in Thunder Bay.
I'm obligated, of course, to play devil's advocate for you on this. I mean, there's some people who make the case that if you allow that kind of you allow that kind of private sector participation, you're going to get a two-tier system. You're going to get some people that are getting the Cadillac care, and other people are getting poor quality care. And is that what we want? Is that a price we're prepared to pay as Ontarians, as Canadians, in order to get more, that we're going to have to accept some tiers in quality?
Yeah. So to be clear, we don't have public infertility clinics where you get lousy care and private fertility clinics where you get great care. We just have fertility clinics. That's it. And some of the services ended up being billed to the government, and some are billed to private insurance providers. So that issue of a two-tiered approach, no, there's only one quality of care. Furthermore, that speaks to, though, a deeper issue, and you're going to have to cut me off on this, but Tommy Douglas, this was his main message, right? He said, I believe, and you can Google this, watch him on YouTube, I believe that no boy should ever risk his leg or his life because his parents couldn't pay for care. Well, you have to stop and ask, what is he saying? Is he saying, the folks that Tim Liddell works with, the orthopedic surgeons, would cut off the leg of a young boy knowing that it could be fixed if his parents could actually pay for it? I mean, that's heinous. basically you're saying there's two standards of care. Is that what you're trying to say? We're going to give one standard to poor people and one standard to rich people. I mean, that's outrageous. Since the 19th century, we've had colleges of physicians and surgeons and solid standards of practice. So this whole thing about two-tier, it really drives me nuts. I better stop, Aaron, because
I got you going. It's on
you go.
me. It's on me. Yeah. We've got about 10 minutes left. I want to take some of the questions. We've got some from the audience. A lot of them already touch on stuff that we've already talked about, and the distinction between profit and nonprofit. One here that I thought was pretty interesting is a name an innovation that government could make with no cost. I'll maybe expand that a little bit for the three of you to chew on. Is there one that they could give that's low cost? Or is there, if I could, you could grant you one wish for your organization, one policy change that you think would be beneficial, what would you go with, Tim?
I think allowing orthopedic surgeons to be able to do some of their procedures in their office and bill OHIP directly. I think that would really open up a lot of patients with minor procedures that could get done very quickly. Again, you keep them out of the hospital. You avoid potentially MRIs, that kind of thing, and I think that would greatly alleviate and again be very cost effective too.
Yeah, pretty straightforward efficiency and speed argument. Dr. Bevan.
Yeah, I have to pick just one. That's hard. I guess maybe I'll give you two. One, I would say digital or electronic triage systems hard to implement some of these bigger systems, but really when you look at how much money you could be saving, it seems like an obvious thing to think about doing. And the other piece, I would just think about how do we take better advantage of these advanced care practitioners or people who can really help alleviate the pressure on the healthcare system right now in different ways, which relates to billing codes, relates to their practice, et cetera, et cetera.
Okay. Dr. Wally.
So the easiest way to save money in healthcare is to provide less care, make wait times longer, close hospitals, right? And that's what we've been doing for 50 years. And so we have to talk about what cost do you mean? Do you mean the total spend, or do you mean the cost per case? So we, without spending $1 on administration or nursing or anything, we were able to decrease wait times in our emergency department from an average of over 6 hours, and at the 90th percentile is much higher, down to shorter than 60 minutes. Overall, so for all patients, like at 90th percentile, so 9 out of 10 patients were seen within less than 40 minutes, and I believe it's down to around 20 minutes now. And so we did that, and we reduced the cost per case because the patients were in the hospital for a shorter amount of time. We had fewer number of tests required because they were seen sooner, and we could deal with their issue and get them back home, get them back to their community care provider. However, shorter times means more utilization. So more people came to the hospital. At least for our hospital, we had a bump in services, actually of a 25% bump on that first year when we made those major changes. And then growth settled back to the background growth of about 6 to 7% per year. So you have to say, yeah, a zero cost change where you get efficiency and better quality and better outcomes, it can be done, but there are always trade-offs. So if you're, faster, better, cheaper doesn't usually work. So faster, better, it's not going to be cheaper. Faster, cheaper, it's not going to be better. And so we have to deal with that trilemma in whatever we're looking at when it comes to healthcare services.
What's that saying? Faster, better, cheaper, pick two?
Yes, exactly.
Yeah, fair enough. I got a question here, pretty straightforward, and I don't know if this is a question that whether it's a normative or a positive question. Could we ever have a fully private surgical center in Canada? Maybe Dr. Watley, what do you say to that?
Yeah, sure. I think we already have some of those in Canada right now, but it begs a question: what do you mean by fully private? So when we say private, we're usually talking about price, or how do you pay for it? Do you pay for it with your Visa or with your provincial health insurance card? And that's all people want to talk about. They want to talk about the money. But when you talk about private, you also have to talk about the type of service,
Sure.
the volume of services, the management of those services, where the service is located, who gets to access those services? Can you deny care to some people because they haven't lost enough weight before they get their knee replaced? So there are a whole bunch of other issues that go into a true definition of what it would mean to have a private surgical center. And people aren't willing to have that larger discussion right now. All they want to talk about is dollars and cents and whether you pull money out of your pocket versus use your OHIP card. So I'm hopeful that it could happen, but right now we're heavily regulated. Well, we don't want too many MRIs. We don't want them done in this particular location. And if you do it, this is the way you must do it. These are all the checklists you have to follow. So with all of that in place, private becomes a tiny little discussion about price. And that's an important discussion, but in the broader business world, they would laugh at us. They'd say, that's not private anything. You guys are
Right.
talking about the dollars and cents within a centrally controlled system.
Right. Anybody else want to weigh in on that one? If not, oh, sorry, Tim, go ahead.
Well, I mean, as Sean said, we have that right now. I think a lot of patients are taking advantage of going overseas, whether it's the United States or Mexico, to get whatever procedure they need done, whether it be cosmetic, elective, or whatever. So I don't see why we couldn't have that openly. I think it helps free up the line. I mean, we have to be realistic that if someone doesn't need to be in the public system and they have the capability, financial
Sure.
resources to access a private system, then that will free up a spot. I think that we have to be realistic in that. So
That's true. Which already happens. They just can't do it in Canada.
That's right. Exactly.
I wanted to ask, because we've just got a couple minutes left, so maybe this will be the last question, and we'll leave it there. But in terms of innovation, are there, for your particular business or organization, is there another country, is there another jurisdiction that you look to, as getting it right or getting it better than Canada? Is there a particular program or particular country that has something that you admire, or you think that Canada would do well to take a look at in terms of emulating? Maybe start with you, Dr. Bevan.
Yeah, I mean, when it comes to what's happening in the health charities for arthritis, I haven't mentioned it yet, but we are embarking on a big national plan for arthritis, or our Arthritis Action Plan, along with 19 other ecosystem champions. So we've looked around the world about what others are doing and who's doing what well. And in particular, we see Australia doing some really great things in terms of bringing the ecosystem together and thinking about a lot of what we've talked about today around how do we bring partners together in the right ways to focus on the right things. So I think there's a lot of innovative models there that we could look at, and other partners in other parts of the world as well. But I would say Australia is a first step for us as being somebody to look to. Good
to know. Tim?
Yeah, I would say any of those countries that have a very strong functioning private public system. I think we tend to compare ourselves to the United States, and that's not a fair comparative. Look at Germany and Norway and Sweden and Australia and New Zealand, and they have very, very strong systems that provide both systems, and I think they're functioning exceptionally well right now.
Sean?
I think it depends on what particular bit of care you're asking about. So, for example, Sweden used to have a care guarantee for joint replacement. If you don't get it within 3 months within the public system, they would pay for it in the private system or send you out of country. We now have BC sending their cancer patients to the United States right now, just last year, because they can't provide service in a timely fashion. So it depends on what type of care you're looking at. Some countries do primary care very well. Some countries do IT very well. I think the caution is when we look around the world, it presupposes that we could grab their policy, copy and paste it, and then just stick it into our Canadian constitutional environment. And in my experience, that doesn't work. So every system is a reflection of the constitutional environment and the people and the context and the geography in which it exists. And so we have the smarts to make a great system here. We just need to let people go ahead and provide great care for their patients. Right now, there are so many roadblocks to innovating and doing what people know patients need.
Well, I gotta say, Sean, I definitely, as a lawyer, I appreciate your sensitivity to the legal and jurisdictional framework very much. All right, I think we're going to leave it there. I just want to thank all three of you, Dr. Bevan, Dr. Watley, and Tim, for joining us today. I think this has been a fascinating discussion. I hope it's given some of our viewers some reason for hope in our healthcare system. I know it can be a frustrating exercise for a lot of Canadians interacting with our system, but hope should spring eternal. There is innovation, and hopefully things will improve as we move forward. So thank you all again for joining us today. I want to thank everyone who tuned in to view, and have yourselves a great day.
Thank you.
Thank you.
Thanks so much, Aaron.
Bye-bye.